Welcome to the next episode of the Many Minds podcast, where our goal is to encourage collaborative community healthcare using many minds for better outcomes. We want to understand what makes your specialty special and how we can support you to provide better care for your patients. I'm Alex Davis, physician assistant, along with Tyler Murray, nurse practitioner.
General disclaimer, this podcast represents the opinions of myself, Alex, and any guests that we have on the show. The content from this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. We're just here to learn from each other and have a good time. All right, well, today on the podcast, we're pleased to have Mignon Boyer. She's in emergency medicine, and that's kind of the subject that we're going to be discussing today. You do dabble a little bit in psych, but I think we're going to primarily stay in an emergency setting, which does obviously span across the different disciplines in many ways. But thanks for coming on the show today. And I think to start with, maybe just introduce yourself, a little bit of your background, and kind of where you're at presently.
Okay, so Mignon Boyer, and I went to school with Alex.
I'm sorry.
Yeah. Shout out to Rocky Mountain.
Yeah.
Uh-huh.
How many Rocky Mountain people have we had?
We're stacking them up. It's just
Rocky
the highest
Mountain?
Quality people. That's what we're after.
This is for you.
Just coincidence. They all
if you
come
want to
from Rocky
sponsor us, hey, we're not opposed. Go ahead. I'm sorry.
I've been full-time at the ER now for about 3.5 years, part-time psych, and I lived in Utah now for about almost 20 years. Grew up here and then moved around a bit and came back.
Nice. So, did you always know you wanted to be in medicine, or kind of how did that come to be?
Even back in high school, I knew that's what I wanted to do. So when I went to school at BYU, my degree was pre-med, planning to go to medical school, but got a little sidetracked with marriage and kids.
Life.
And decided to wait a little while.
Kids, they'll do that to you, I'm telling you. Derail you. No, just kidding.
It was a good derail.
Yeah, I know.
No regrets whatsoever. Yeah.
No regrets.
And then once they got old enough.
That's always funny. People say it's always funny.
I don't know why.
Anyway.
Sorry. Go ahead.
No regrets.
Just once they got old enough, the youngest were in high school, decided it was time to go back, and of course had to go back and redo all the prereqs and everything. And
that's a commitment.
It was a lot, but it was good to try and figure out if I even remembered how to learn new things and go back to school. And so then finally
that's awesome.
Got into PA school, and that was a great experience.
And you transitioned right into emergency medicine?
Yeah, it was the year we graduated was COVID, when really not a lot of places were hiring.
COVID.
Yeah.
That's the storyline.
It was rough.
The health pandemic shuts down the healthcare market.
Yeah.
Yes.
So
But also opens doors because there was a huge need, right?
Yeah. Yes, in certain specialties.
And
then other specialties, they were letting a lot of mid-levels go, because surgery, anything surgical, they weren't doing. It was rough trying to get a job. I felt like during that time, but
that's true, because I started with Summit in 2019, which was right before the COVID pandemic, and we completely shut down, and we had to transition to telehealth exclusively. I literally was a new provider, and I had a laptop in front of me, and I was working up potential surgical patients, only seeing them from the neck up, and you don't realize, but you can miss a lot of things when you're just doing telehealth. Imagine, So, but it sounds like that gave you an opportunity to get into the emergency setting, is what you were alluding to, right?
Yeah, emergency and psych. Because COVID played it was rough on people's mental health.
So you were part-time ER, part-time psych, or were you?
Initially, I was just PRN ER. That's what they hired for and had room for, and full-time psych. And then about a year and a half later, transitioned to full-time ER and part-time psych.
Nice.
Which also, working the ER is also part-time psych.
Yeah,
you're
correct.
You're well-rounded. Yeah, that's fantastic.
So you get to do it all. How's your experience been in the ER then? As an advanced practitioner, it sounds like you've seen a few different settings.
I'm sure the listeners want to know, what does your world look like? What's your day-to-day kind of?
Well, if you want to learn a lot about medicine, the ER is a great place for that, because you just don't know what's going to walk through the door.
It's true.
So, it's fun and exciting that way. It's also scary that way.
Yeah.
There are a lot of days, I think nowadays, the first 2 years, I just thought, I'm never going to feel like I get this. I'm never going to feel like comfortable, walk away from a shift, not worrying that I missed something. Or after 2 years, it got a little bit better, but now I'm going on 4 years, and still, I'd say at least half the shifts, you go home wondering and worrying, like, did I catch everything? Did I send somebody home? Did I?
Yeah, it's a heavy responsibility.
It is. And, that's where you just give really good return precautions. And it's like, if anything concerning basically comes up, you just come back. Like, we didn't find anything today, but your symptoms are real. So if something happens, you have to come back.
And that's interesting. I was thinking about that, like just the buildup of being a competent provider in the ER setting. Did you feel like you had adequate training? Like, do you feel like there was appropriate training protocols in place for the ER setting?
Yeah, as much as is possible. The ER,
and it just throw you in and
urology,
put you into a room? Figure it out?
Yeah, really. That's where some things like... definitely psych physical exams, not even really part of that. So you rely heavily on history and physical exam to know even which tests you can order. But the nice thing is with ER, you have all those tests like at your fingertips. Whereas super nice. In clinics and family practice,
you don't have that.
You don't have any of that.
We talked at one point to a family practice physician, and he was telling us some of the stumbling blocks or some of the difficulties for him is a patient where he's concerned. It was a specific scenario. He was worried about like a septic joint or a septic bursitis. And so he just wanted to do like a basic CBC of just go see what your blood counts are. And is there an indicator of infection? And he said if he were to do that as an outpatient setting, it would have been a week until he got results back, which is wild.
That is true. Yeah.
Way too late for something.
Way too late. Yeah. That's not appropriate care.
But then you're balancing, you're teetering on this idea of like, you don't want to abuse the ER system, right? And so I think you probably see a good share of both sides and like trying to find the balance from an outside party referring a patient and saying, I think the emergency setting is the right option here. What would you say to that, or what would your counsel be there?
I'd say probably close to a third of our patients come to us straight from the urgent care. They went to like a primary care provider urgent care setting, and the urgent care, is kind of designed to recognize
triage and manage them.
And so we get a lot of patients from urgent care. I felt like initially when I started in the ER, because I'd done a little bit, about a year and a half in family practice, it was a real shift in thinking of how do I like spare costs, not run extra tests, do things step by step. And I had to quickly adjust to the fact that they'll be in the ER for a week if I do that. Instead, it was like anything you think is possible. You order the labs. These are all the things we can do now. There's a lot of things that you can't get in the space of a couple hours. But between imaging and the labs we can catch anything life-threatening or emergent. And it was like, if people are coming to the ER, you have to adjust to the fact that they're not here to save money. They're here to find out what's wrong. And they wouldn't come to the ER if they weren't really concerned. It's a good perspective. So I had to realize, okay, don't try and save anybody money. Not that I'm wasting their money, but it's like they were worried enough they came to the ER. So they want answers. They're not worried about penny pinching. So you just order what you need to order.
Correct.
Yeah, I like that mentality.
Make sure you don't miss something.
How about the sentiment he was alluding to of maybe providers or patients being sent to the ER and maybe not trying to abuse the system, I guess, but there needs to be a balance of when we feel it's appropriate of, I can't get a CBC back today. You need to just go to the ER. Do you feel like you guys are inundated or overwhelmed with these types of scenarios?
I'd say the abuse comes more from a lot of people who don't have primary care providers, and so they come to the ER for things that are truly not even urgent, let alone emergent. They just, that's where I feel like there's abuse, and it's not... they don't have insurance, or for whatever reason they don't have a primary care provider, and urgent care clinics can refuse patients for inability to pay, and the ER cannot. So the way our system's designed is just that's going to happen. So
those people are going to end up there. Does that how's the workload then? Do you feel like you guys are overrun and overworked and overwhelmed, or does it seem manageable?
That is a shift by shift thing. Some shifts are crazy stressful. Every minute of the shift, I feel like my head's below water. And other shifts, it's like, okay, I'm doing okay. I got this. Like, I'm in control of what's happening here. And then other shifts are like, oh, okay, that was actually
I think there's a certain personality that just fits the ER setting, because you've got to be able to roll with the punches, for lack of a better term. Like, crap's going to hit the fan, and you got to be able to just remain a level of calmness and be able to weather the storm, if you will. And so I just think for the listeners out there that are interested in the ER, I think it's good to know that, you know, it goes without saying, right? But the ER can be a tough specialty. Yeah. Like probably you're in the trenches probably more than you're not, if you will. But maybe you could clarify on that. You feel like that's the case, like pretty demanding and
very demanding, high stress. You know, when you leave a shift, you're exhausted. There are lots of nights where it's like, I don't want to talk to anybody. Don't ask me for anything. Don't ask me any questions. I just need to to decompress.
Yeah.
A lot of shifts like that.
There's got to be a level of, you know, satisfaction, like, because that's what brings you back, right? So what is it that you find in it? Is it just the pure, you know, in and out kind of triage mentality of it? But like, what brings you back, I guess?
What do you like about the ER?
I love that you don't know what you're going to get. So you see all kinds of things. I'm always learning and feel like I'm progressing as a medical provider. So if you really want to know a lot about medicine, like, you know, it's like a hospitalist or ER, they see a lot of things. I do like kind of the excitement of the ER. But yes, it's tiring and stressful, but it's also very enjoyable and rewarding, especially when you find the problem and you get the person the care they need, or you get them in touch with the specialist they need, and you feel like you got an answer for them. Whereas, you know, urgent care or primary care clinics or whatever, it's going to take them a week, you know, or more. So it's very rewarding. It's just also, it's just more stressful.
Yeah.
And to clarify, I guess, for people that don't maybe know exactly the setting that you're in a big trauma center, kind of our regional trauma center for the area. So it's a big, busy ER. How many bays are in the ER?
Trauma bays 4, and then it's broken up into different hubs, and those different hubs open up throughout the day as we've seen trends or patterns of when the ER gets busier and busier. So at any given time, more nurses and doctors and providers are coming on, and so there's 4 hubs. Each hub has about 10 rooms.
Wow,
that is
separate from the trauma rooms.
So you got 40 plus open bays in the ER, and it's
you've never seen that though, right? Like 40 beds occupied?
No, most evenings it's full, and there's people in the waiting room. And definitely holidays.
That's wild.
So that's when it gets really stressful, is when the waiting room's stacking up and
you got people in the hallway, you're triaging.
Yeah.
That's crazy.
You got to move people through, but you can't miss anything, and you want to take good care of the patients you have, but you know there's people in the waiting room that are sick too. Anyway, it's
I can see that adding up.
Yeah.
And you were talking about what I was alluding to earlier by that is being a bigger trauma center, that it's not always investigative and find what the problem is. Sometimes it's a pretty straightforward gunshot wound or whatever the major trauma is. Do you like being involved in those situations?
As PAs, oftentimes we're not involved in a lot of the traumas, because at a trauma center like that, we have so many great specialists. When they page a trauma, we get neuro down there, we get, cardiology, cardiothoracic surgery. We get so many specialties. It's wonderful, but it takes the load off. And to be honest, all the other patients in the ER still need to be seen, and those traumas and codes are very intensive and time consuming. And so when you get pulled into something like that, the rest of your patients just kind of fall by the wayside for an hour or more, which is rough. So I feel like as a PA, a lot of my role is, because there's all these specialists taking care of those things, is to keep all the other rooms moving and the other things going. So. And
correct me if I'm wrong on this, but when I've seen the ER setting in that scenario, there are quite a few advanced practitioners that are involved. They're subspecialty, right? Like trauma, but they're active participants in those traumas.
Yeah. In fact, those are a lot of the specialists that come down. It's not necessarily a doctor. It could be a PA or an NP.
But it's been cool to see.
Yeah.
Dr. Edwards, I remember one of the trauma APPs, there was a trauma, and he was talking about kind of the utility of an APP or what they can do in their role. And he's like, oh, yeah, they can put an EVD in the ER trauma setting. And I'm like, wow, I've never even thought about doing that. Like, screwing in through the skull and putting something in. I'm like, wow, that's wild. But it's cool to see the amount of autonomy and kind of roles that we can play in that setting. And then reassurance, it's kind of there's a nice reassurance if you do go into the ER setting that you do have a big team. Like there's a lot of people that are going to support you and help you, so you're not stranded. And I think that's maybe, again, some level of reassurance that if you go into that setting, you're not alone. There'll be people that'll help you and things like that. So that's nice. But
what's the most rare diagnosis you've come up with at the ER?
I always wish that I kept better. I don't know if notes is the right word, but like
to keep it.
Yeah, to remember
the memory bank.
Some of these things, and I don't, and then I can't remember everything.
Of course.
I'm the same way. My family always tells me, keep a journal of all the stories that you had, because you remember them sporadically and then you're able to spit them off, and it's funny at the time, but over the years you start to lose that knowledge. And so it's so true in medicine too, because I think about all the experiences that I've had where I was a bedside nurse, and you can imagine some of the stories you can probably conjure up with bedside nursing care. And my wife's always telling me, you should write them down because you're going to forget them. And sure enough, I've forgotten a lot of them.
You forget until someone says something, and that
sparks you. Yeah.
I would say the most, I don't know that they're the rarest, because ERs, the zebras are still the zebras in ER.
Yeah.
And they don't always present there first, if they're, oftentimes I think a primary care provider finds them, because those tests are not like, it's not a CBC and a CMP, you know what I mean? It's not those things that they can find. So a lot of times we don't find the answer. And like I said, their symptoms are real, and I have to send them back to a primary care provider, somebody to find the zebras that we don't have the ability to test for. But,
and you don't necessarily get feedback on that then, right?
True.
Like that's, you kind of, your chapter is done for that moment in time.
If they're within Intermountain's hub, and I can access their records and see any kind of follow through, like, what other imaging
doing
was
your
done,
due diligence
but even a lot of those specialty labs are going to LabCorp, like others, and so I can't ever see what the labs even resulted at. But
I guess I didn't really look at it that way.
Yeah. There's probably a lot of times you send people away like, something is happening, but we don't know exactly what. So hopefully we can get,
I'd say at least half the time.
Really?
When I'm talking to them, I can tell them, I said, I can't tell you what's going on, but I can tell you what's not going on, because these are the things I can test
You're
for
ruling
here.
out, right?
These are the things life-threatening and emergent, and then I have to make sure they know it's not that I don't believe you. You have these real symptoms, but I can tell you I can't test for them, and I can't find the problem, but here's who I recommend can.
Yeah.
Anyway.
Interesting.
That's wild. Do you ever run into the situation where, so this is the thing that gets me in the neurosurgery space is, and this is tedious, but a patient comes in for one chief complaint, and you go in and you address the chief complaint, and then like 10 other complaints happen within that span of time seeing the patient, and you're like, when does it end? Like, I've only got so much time. Does that, I can assume that happens in the ER.
Yeah, especially with the time pressure to keep things moving and get patients in and out.
What about this mole right here? You're like, well, probably not the best person to look at that.
Why are we looking at your moles?
Yeah.
I oftentimes
I think they're connected.
Politely have to say, these are the things I can test for here. These are the one of the docs, when goes in a room, depending on what's going on, will say, so what's the emergency that brings you in today? To kind of help them realize we're focused. This is an emergency room, and this is what we're focused on. We're not going to deal with every mole or thing that you want checked out by a dermatologist. I don't know that really helps them narrow things down, but it's really the people who don't have healthcare outside of the ER that tend to do that.
One stop, one shop. Yeah.
We get a lot of homeless, especially in the winter, if they want a warm bed to sleep in, and the ER can't refuse anybody, so we get a lot of that. True. And they'll, I think, make a complaint that gets them a bed to sleep in for a few hours, a meal, and things like that.
As a human, you kind of like that emotional side of you is like, but then it's like, you can't have somebody utilizing resources that doesn't need, not to say they don't need, I'm just saying, like, in general, the concern, the balance, it's such a delicate balance in the ER setting, I guess is what I'm trying to allude to. But that's crazy. Can't even imagine but you love it. So tell me about your shifts. Let's talk about what a week looks like for Mignon.
I think every ER group does a little bit different. Our ER group, we staff Utah Valley, Orem Community, and Spanish Fork. Orem Community and Spanish Fork are more rural, so we don't have all the specialists there, and we transfer a lot of things to Utah Valley or even Salt Lake. The way we do our shifts, we do 3 on and then 3 off. Our 3 on are anywhere from 9 to 10 hours, and they'll be at the same time for those 3 days, and then we have 3 off, and then we do a different time for 3 days. And so for the 3 days, we're on the same schedule, but our schedule varies all the way through the year. And if your 3 on happens to fall on a weekend or a holiday, that's your shift. The nice thing is, because I think a lot of groups, when you're the new guy, you just get the really crappy shifts every holiday, every night. And so I liked when I joined the group, and it's just fair. Everybody's working the same stuff.
So how many hours a week would you say then? I couldn't calculate.
So 3 to 4 days a week then?
Because it's 3 on, 3 off. So technically it's 4 shifts a week.
Yeah.
And like I said, they're about 9, some are 10 hours. So you're close to 40 hours.
Do you feel like that is about the time frame you're spending, like in that setting, like mentally in it, like documentation, seeing patients, like it's 40-hour work week, would you say?
Yeah, very commonly you'll have to stay after for an hour or more to do charting, to get caught up on charting when the shift got crazy and you got behind.
Sure.
That was a lot worse when I first started. I'd be there for 2 or 3 hours after, trying to make sure you're charting correctly and you're covering everything, and
I've
preparing
been in for 6 years and I haven't figured it out yet. So. Yeah, I need to talk to you after and teach me the ways. So.
The ER charting, am I wrong? Is it pretty concise?
Yeah, it is. Like I said, we're limited on what we can and can't get here, and we get our results pretty fast. So it's, it's like generally I get my answer, and then they either get admitted or they go home and follow up with a specialist, or I fix the problem and they just get to go home.
Yeah.
We do a lot of pre-programmed like for abdominal pain, a lot of it is the same, so you just have to edit some things. And once I kind of figured that out, now it's gotten a lot better and faster.
How many charts in a shift? What's average?
Average is probably about 15 patients a shift.
Okay.
So I think the average length of time per patient in the ER is about 3 hours.
Yeah, that sounds about right.
That's so recently I'm on call right now, so it's after hours call, so patient has surgery or there's an issue and they call into the office and it goes to the answering service. They page me if it's something they think an APP can answer. And the ER called me about a patient, and it's just, I feel this sense of responsibility, because it was a question that I really needed to defer to the surgeon and get some context on what his opinion was. And then I'm like, but this ER physician's waiting, or provider is waiting to get this answer to decide, what are we doing with this patient? And so there's, I think sometimes we forget about the fact that when we hang up the phone and say, we'll get back to you, you're waiting for an answer to do something with this patient. So I think being a little bit sensitive to that is probably a good reminder for us providers.
I will say a lot of the pressure comes from the patient themselves. If they've already waited an hour or two in the waiting room before they saw a medical provider, then they got back in the room and they maybe waited 15, 20 minutes, which to them feels like eternity, especially if you're in pain, before they saw a medical provider. And then they're waiting 2 to 3 hours for results and everything to come back. And so I feel like there's a lot of pressure from the patients to get, they think I can go to the ER and I can get my answer immediately. And they get,
you could spend a whole day in the ER.
And angry when I say, I can't give you an answer. I don't know why you're having this symptom. Some get upset. Others are relieved that I can tell them all the things it's not. But a lot of it is the impatience of the patients. They want to get in right away. They want their answer right away, and then they want to leave. And
it's hard. And the patient's perspective, and having been through that on the patient side of it, it's also hard to have no sense of, it's really abstract, the timing and what's happening, and you can't see behind the scenes. You don't know what's happening behind the scenes. You have no idea, and you open the curtain and look out, and there's just people everywhere, and you don't recognize any of them, and they're all doing their own thing, and you're like, Do you know?
Forget about us?
Did you know we're still here?
Yeah.
I'm sure they do. Everybody's doing their job, like you're alluding to. But yeah,
I've gotten better about letting the patient know from the get-go. Average length of time is 3 hours before I have answers for you. I don't come back in frequently. I come in when I have answers for you. You know, they have their little remote with a button on it if they need anything.
Yeah.
Which I make sure I hand to them and say, if you need anything, push the button, let us know. Somebody will come in and take care of it. And just make sure they know. I didn't forget about you. I'm just, when I have information for you, I'll be back in. Because otherwise they do sit there and wonder, like, they don't realize how long these things take. So it's just about giving them, setting appropriate expectations. And then they are very understanding and patient. But.
That's huge.
That makes sense. How about compensation for that? So if you feel like, if it's a fair compensation, are you guys salary? Is it shift based? Is it hourly? Is there based off of production, or what? How is your structure?
Again, probably every group is a little bit different. Our group, because we're contracted with those ERs, so I don't work for Intermountain. The way our group does it is it's shift work, so you're paid hourly. And initially what they did is they kind of did a quarterly bonus to kind of cover for, because we pay for our own malpractice and our own health insurance and things like that. Like we don't have those benefits, and our own CME. So that it was kind of this quarterly bonus to just kind of cover for things, and a monthly stipend as well, which more than covers. Like it's great. It's very generous, and makes it so that all those things are totally possible. I felt like the compensation has been pretty fair for what we do. They recently just changed it to kind of a different pay structure where it's you have your hourly wage, but then it's RVUs in addition. So it is, the more patients you see and the higher acuity, and the more they bill for it, the more your kind of quarterly bonus is. But
do you like that structure? You feel like that's a good way to go?
I think it's probably fair. If on any given day, if it's not a busy day, you'll see less patients, and if you end up seeing, all the coughs and colds that come in, and no high acuity patients, it will be more variable. But.
Yeah, I was going to say you're completely reliant on the flow of things, because you don't get to predict how many patients you see or the complexity of each patient and how much time you're going to spend with them. So that does create a little bit of an unknown variable to it. But if you were able to look at it long term and say, average wise, we're all going to see about the same number of patients, and so therefore the RVU based setting is going to kind of pay out. And the question is, and maybe you don't know this, but reimbursement, there's a complexity, right? Like if an acuity rather. So if you're seeing a cough or cold, like that's not going to pay out as much as someone that comes in with, as a trauma 1 or whatever.
Yeah.
Is it just next person up? Is there somebody assigning who gets the next patient and who's taking on a certain workload, or how do you take the next patient?
So the way our ER works is there's a board that just has like the chief complaint and the name of the patient and like age, very basic information. If they've been triaged, there's a short little triage note of maybe a sentence or two to kind of give you an idea of what's going on. Every shift you're working with different providers, so some providers kind of like the every other kind of thing. That doesn't always work, because if somebody's in on a code or a trauma, you can't just sit there and wait to take a patient till they come out and pick up their patient. So it's really more about watching how things are going. Where's the need? As a PA, we work multiple hubs. So when they open a new hub, if that doc, gets 8 patients all at once assigned to him, as soon as that hub opens, they can't see all 8 patients at the same time. So you go over and try and help. And it's really just about paying attention to what the need is and trying to keep things moving. You're
at your own will to go grab a chart and go take a patient, not that somebody's assigning them.
Correct. Yeah.
Okay.
Yeah. And oftentimes you have no idea what you're walking into. The triage note says abdominal pain, and you get there and not even abdominal pain.
Are you ever debating with your fellow colleagues, like this one has your name all over it? I can just tell that just by this brief description, you're the person to see this.
There are jokes like that it's like
20-year-old female abdominal pain. I think that says Tyler Murray on it.
let me take a crack at it.
There are jokes, and especially because some of the patients, you start to recognize their names. They're there quite frequently, and you get to know them very well, and it's like, okay, it's your turn this time.
100%. 100%. That happens in every specialty.
The last 5 times. Yep. Yeah. But yeah, no, you really can't. You can't pick and choose. You know, in order to keep things moving, you just have to. Yeah. You know.
No bribery, no slipping somebody. You got this one. All right. I'm gonna
do you have a preference? Do you like a certain patient presentation, or what do you feel comfortable with?
What do you like to do? But I've learned that what you think you're walking in on is never what you think you're it actually is. So, you know, it says rash. So you walk in and it's never shingles or something like what you think you're going to see. Instead, it's bloody diarrhea and a rash and no vision in the right eye, or what, you know what I mean? So I've actually learned not to try and pick and choose on what the triage note says, because sometimes you think,
that's just a small little snippet of what's actually going on.
And the most interesting cases, you just never know what you're going to get. So you learn a lot.
Yeah, it's almost better just to like next person up. Just, you know, hey, I'm ready. Let's grab a chart.
And really, truly, the importance is keeping things moving in the ER. So if you're sitting there trying to cherry pick, that's not going to work that way.
That's not going to be a great team environment. So it sounds like you've got a good niche of just like your team works well together, and everyone's going to take responsibility and put in the work and carry the workload.
Great support. The nurses are wonderful at, you know, if something changes, like while the patient's there, coming and telling you, hey, their blood pressure's starting to go down, or, you know, so it is definitely a team effort. And
how much provider or physician rather APP interaction happens in the ER setting? Is it really just kind of you're in your own world and kind of autonomously doing what you do, and then occasionally checking in, you know, or bouncing things off of the physician?
Obviously, initially when I started working there, I discussed every patient with whichever doc I was kind of in that hub. Just making sure I was doing things right. I mean, even then I was trying to learn the computer systems, making sure the orders were put in correctly. On a really, really busy shift, there's just not time for that. But any patient I'm worried about or have questions or things just aren't making sense, the docs are great about. And the docs on call, you know, I can call any specialty and say, hey, I don't know what's going on here. These are the results, but this is what I'm seeing on physical exam. And that is the great thing about the ER is I have so many specialties at my fingertips. If I don't know what's going on, somebody most likely does.
Being one of those consulting specialties on our end, what advice or what would you say that would be helpful to help you do a better job? What's helpful for you on our end of the conversation?
Like if we're sending a patient to them, or if they're sending one.
If she's calling for a specialty consultation.
Oh, okay.
Right? Because you're talking about referring or speaking to all the different providers. What's helpful for us to help you do a better job?
Don't tell me to get an MRI.
Okay.
They take so long.
I know.
It really messes with the flow of the ER, and I'm kidding. Obviously, hopefully by the time we've called you, we've already gotten the MRI.
Sure.
So it's really, I don't know that there's anything.
Duly noted.
I don't think there's anything specific that I can tell you other than just being aware that time is always a little bit of a constraint in the ER. There are a lot of times where if we have any reason to admit, you know, this person's got symptoms of cauda equina, but they also have a blood clot in their leg, and they also have this, and they can't bear weight on the leg, and they're a fall risk, they're going to get admitted, and they don't need to wait in the ER for the MRI, which takes hours.
Absolutely.
And then to get the results. So we'll get them admitted and have them get the MRI upstairs. So it's about kind of moving things through appropriately. And somebody who has no other reason to be admitted, then they're going to wait for the MRI and our consult. And so
interesting. Okay. Another fun topic. I don't know. I'm a little bit interested to hear what you would say, I guess, is what would be kind of the innovative, new, exciting things in the world of emergency medicine? Is there anything up and coming or anything coming down the pipeline? I don't know. Are there national conventions for emergency medicine?
I would imagine so.
Probably.
Conferences. Oh, yeah. For getting like CME and...
Yeah. But based around emergency medicine, naturally. Yeah. And I'm sure they have their national organizations and whatnot. But in your experience, I guess, what's kind of the cool new things coming
I don't know if there's kind of more changes like in stroke protocol, or, you know, they've, you know, after a 30-year study done in Canada, they figured out that this is what's better for stroke or whatever.
Sure.
I don't know that it's like new equipment or some fancy new device or anything like that.
Yeah.
I will say sometimes things, now bedside ultrasound, things like that have changed over the year, and they're so quick and easy to get. Like, things do get better and better over time, but I don't know that I can pinpoint like one particular thing that I'm just so excited about. But I will say, like, just the fact that somebody figures out, who's doing all this research and figuring out that what we used to do for strokes just isn't ideal anymore, or this medicine's not ideal. This one seems to have better outcomes. It's great that somebody's doing all that, and then they've decided that this is kind of the new recipe in the ER. I mean, this is how we handled this particular complaint.
I got a good friend who's a family physician, and he takes PRN shifts in the ER still once in a while, and he was telling me what he envisions the future of the emergency room would be. Like, you're going into any other venue, and they've got just those little metal detectors that you walk through. And he says it'll be the CT scanner. Everybody into the ER just passes through a CT scan on their way in. Just simplify things.
Actually, that would be amazing. Right? It really would.
We know, a broken arm.
Imaging of everything that fast. The problem with that is that I'm on the hook. You got everything you found on CT.
As soon as you've opened that door and your name's on that identifier that you saw that patient, you got to be responsible for whatever findings. So for
preventative medicine and things like that, that sounds wonderful. For trying to keep the flow going through the ER, that sounds terrible. Yeah.
Okay.
Tell me with your practice present, how much AI is integrated, if at all, or is there plans to have AI integration?
Yeah. Intermountain Health just recently integrated DAX AI, which works with the current program that they have. So we actually just use our cell phones when we walk in a room, hit record. So you'll just put in like room 13, basic information. The software on our phone doesn't allow us to you can't send it to anyone or anything like that. So it has like patient privacy.
HIPAA compliant type thing.
Mm-hmm. So, but you just hit record, you walk in the room, introduce yourself. It records the whole conversation. And then, so when you go out and you place your orders and you start your chart, I can just say transfer HPI, and it all populates in this nice, coherent.
Does it do a pretty good job?
It actually does. I don't think it did initially. We had a couple ER providers who have been working on it for months before we
training it
started
to
using
do it.
But AI learns pretty fast, and they got good pretty fast. So
cool.
It's actually saved you some charting time on charting, and just it's funny, the details that I miss when I'm, someone says something and I think, oh, that's important, but now I need to ask this question, and I might miss the next little thing that they said, and AI will catch it. But sometimes they don't hear well, where they're like, they'll say, I don't have this versus I do have this, and I'll have to go in and correct it. So you definitely have to go back and read and make sure it got it correct.
Verify.
But it does save me a lot of time.
Does it ever spit out any differential diagnoses? Is it that advanced yet?
It's starting to take your job, isn't it?
Well,
that's what we're trying. That's what we're trying to get.
Differential diagnosis. Preferred diagnostic workup.
Yeah, it'll only put in like two things, and the differential diagnosis is never like two things. So
could be sinusitis or it could be cancer.
Right. Yes, that's what. Yeah. And it's definitely geared towards clinic, the way it writes things. So initially, to set it up, we had to adjust it to try and make it work for the ER setting. And there's a lot that I still have to do, like all my medical decision making and results and things like that. You have to
still need to be
talk through. Yeah.
Gotcha.
But it still saved me a lot of time. And
that's cool.
And the recording lasts, I think, only about 30 to 60 days, and then that is no longer part of the medical record. But and I guess that can be a good thing or a bad thing, like as far as like litigation down the road.
Sure.
But again, where the recording is catching everything, in theory, I don't go back and listen to the recording, but it should be on that.
That's something
screen.
to think about, though, because if they could store that in the cloud, but that's so much information. So
it's only stored for a set amount of time, and if you
but
think
in the future, it may change because what you were just alluding to, just having a recording. I mean, there's proof is in the pudding, more so than even what I document is like what was said and all that transpired in our conversation. So I guess it could be used for or against you, but it's interesting.
I would like to think it would be used for you. I don't think there's many people that are doing anything with malintent or rude or inappropriate or anything like that. Absolutely. So I would imagine it's protective mostly. But
absolutely.
Anyway.
Well, to finish up, we always like to wrap things up with story time. Do you have any fun or exciting or entertaining or unique patient experiences you can remember?
She works in the ER.
In your time in the
ER. We're really not asking you the question, right? Like, you just tell us a funny story. We want to hear it. Yeah.
These are the ones that I wish I wrote more down. I do write some down, obviously with no like private patient information or anything. But one of the earlier shifts in my ER career, the triage note said ear pain. So, if that gets you some idea of when I learned not to expect anything when you walk in the room.
I'll take that one. That one seems like I got that one.
Is this a 2-year-old or a 20-year-old?
Like 50. He was about 50.
Okay, ear pain, 50-year-old?
Yeah.
Okay.
Which, you're thinking shingles, earache,
Yeah.
So I walk in the room, the first thing that hits me is the smell. Really, really horrible smell. So I had to walk back out and find a face mask and put some smelly sauce in it so that I'm not, gagging in front of the patient, which is very embarrassing.
Yeah.
So put the mask on, go back in, and it was just this gentleman who lived alone, not homeless, but lived alone, and he was not mentally ill, meaning he was alert and oriented, very coherent. And he just said, this ear hurts. And he'd had this hat on that kind of had the earmuff things on it. So, it, and if I remember right, it was too like summer, like 90 degrees out. So I thought it was a little strange that he even had the hat. But we removed the hat, and all the maggots started falling down. And he kept saying, it's dripping, my ear's dripping. He thought it was just like an ear infection that had ruptured maybe and was dripping. And had no idea that there were maggots
in the ear or in the hat,
and that had eaten
Down,
most of the ear.
Are you listening to this?
Oh no!
So, most of the ear was gone. There was a little nub of the earlobe left, and to be honest, the maggots had kept the guy alive and not septic. They'd eaten all the dead tissue away. He had a ton of AK, which became cancerous, on his scalp, back of the neck. I assumed that, the other ear had it. I assumed that's what was going on in that ear that led to the dead tissue. And then the place that he was living obviously was lacking some hygiene, and the maggots had taken over. And I guess it was shocking to me that you can go that long without ever looking in a mirror or interacting with somebody that might say something, even like,
excuse me,
how do you get your groceries? Like, doesn't, somebody at the grocery store say something to you?
Somebody should have seen, anyway.
So that's always everyone's first question is, so was he like,
is he homeless?
Like, how did he not know that was happening? And I have that same question. So anyway, just had to get imaging, checked blood work. His blood work was like squeaky clean, no white count, nothing, again, the maggots had really saved his life, but they'd burrowed in so far, he basically lost his hearing in that ear, and the tissue was like completely gone. So we called in ENT, lucky guys. The doc and I spent a long time trying to remove the maggots, and every time we'd pull some away, they just kept coming more and more, taking its place. And it was very painful for this poor guy.
I can only imagine
dishing out what he was going through crazy. I thought, how's he breathing? But so finally they got to the point where, because the maggots were so far in, the ENT provider was like, we're just gonna have to take him to surgery. They're gonna have to do a skin graft anyway. this is a big surgical thing, and I think he ended up transferring up to Salt Lake, if I remember right. It was something more than they could do even at Utah Valley. And so
I imagine that's tough to keep the sterile field clean
with maggots
dropping, crawling and dropping.
And I was thinking like some type of vacuum or something, just suck them all out, but that's not the right response.
Shot back.
Sorry, it was my immediate response.
We have the little suction device there, but that was just not going to cut it.
Yeah, I get it. It was more involved.
Clog the sucker. That's why.
Dang! Wow. Okay. Wow. Yeah, the ER, you see it all. There's no doubt about it.
Yeah. We should have teased that story to begin with.
That would have been a good one.
If you're wanting to listen to a fantastic patient story out of the ER, stay tuned. This is going to be good.
I actually, when I tried to explain to the patient what was going on, he didn't believe me that it wasn't dripping. Those were maggots falling. And I actually had to take a video of it to show him, because because he wouldn't believe.
Is this guy freaking out at this point?
No, he actually stayed pretty calm. I think he too was like a little shocked that he like didn't recognize that that's what was going on. So because it's like, well, that doesn't happen overnight.
No,
that whole ear was basically gone. Like that takes time. So I don't know how long, but the pain finally got bad enough when they burrowed in deep enough.
He was like, yeah, we're not doing this anymore.
I'm disappointed in James now. James came over from ENT and did an episode with us. And you just outdid him.
Out of the water.
You just outdid the ENT guy.
Well, that's the ER. It's better than Christmas morning. You just don't know what you're going to get. So.
Yes.
Oh, man. Okay, awesome. Great way to cap it off. Mignon, thanks. This has been a ton of fun. Tyler, what'd you learn about the ER today?
I learned the time. No, I think it's been great. I appreciate it, actually. Just it's more of a refresher and a reminder for me of the emergency setting and all that it entails. I think most of us are very familiar with the ER setting, maybe not intimately as far as being a provider in the ER setting, but we recognize what the ER provides for the community. And I think you're a great example. I think it sounds like, obviously the team, it's a collaborative team effort. And I think just a good reminder for us of how we utilize the emergency setting. And it doesn't sound like you're deterring us from sending patients to you, but definitely encouraging us just to make sure we're collaborating appropriately and keeping our doors open just as much as you guys keep your doors open. So it's been great to have you and learned a lot. And I'm going to clean my ears tonight. Maybe have somebody look in them just to make sure. And I think it'll be a good night.
I think if you just look in the mirror once a day.
Yeah, I try not to do that.
He spends too much time in the mirror, I think, is his
Don't
problem.
ask my wife.
Look at that hair.
Don't ask my wife. She's like, why are you looking in the mirror again? Like every time you walk by, you just kind of glance. Don't do that.
Are you flexing again?
Yeah. You know me. It's been great. Thanks, Mignon.
Thanks,
You've been awesome.
Thanks
we appreciate your knowledge and your willingness to come share your expertise with us. So
great.
It's been fun.
How would somebody catch up with you if they had interest and wanted to reach out to you? Can people reach you online somewhere?
Oh, yeah. I am online, although I don't spend a lot of time online. But like email, if that works.
Great.
It's just my name, mignonboyer@gmail.com.
Perfect. And then you're at the Utah Valley Emergency Department. And what's the name of your group, though?
Utah Valley Emergency Physicians.
Utah Valley Emergency Physicians.
UVEP is what they...
Perfect. Okay, and we always like to connect with people. You can find us on Instagram, Summit Brain, Spine, and Orthopedics. On YouTube, it's the Summit Medical Institute. And then we want to see people in person. So come hang out with us Tuesday mornings, 7 a.m., Mountain Point Hospital in Lehi, Utah, for our interdisciplinary case discussions. This is episode, we're up there now. We're almost hitting the 1 year mark. I think this is about number 25. So
Dallin just said 25.
Dallin gave us a signal of 25. It's been good. A lot more good ones to come. I'm looking forward to it.
We're going to wrap it up. We're going to do a couple more, and then you and I are going to...
We're going to have a recap.
A recap of all the stories. I bet yours is going to be in there, Mignon. It's going to make the recap for sure. So I'm excited.
Shout out to our production team. Speaking of Dallin and Amelia, behind the scenes, putting this together for us. We appreciate that. Tyler, always appreciate you being here. And we look forward to the next episodes coming up. I'm Alex Davis.
I'm Tyler Murray.
And we'll see you guys next time.
Peace.
Are you ready for this?